Fabulous. Hi everyone, yes, my name is Elizabeth Hogg and I'm presenting my research on maternal accommodation of paediatric BDD, looking at the clinical correlates and associations with treatment outcomes as well. So I thought I'd start with some definitions, and I know BDD is very well known to you all, and family accommodation probably is too, but I will clarify it here. So this refers to the behavioural changes that parents perform with the intention of reducing their child's distress and or support their present functioning, and this is in the context of a particular psychological condition and the needs there. And examples of this include providing reassurance, assisting avoidance of feared situations, participation in rituals, and following desired routines. And as others have done, we'll think about the research context 10 years ago, so back in 2013. To our knowledge, family accommodation hadn't been explored in BDD at this time, and perhaps this makes sense when we're thinking of the field and where it was at. So the first randomised control trial of CBT for BDD in young people was being undertaken by colleagues in this room at that point in time. So I guess the priority then was really about developing an age-appropriate treatment protocol for BDD for young people, and research into kind of potential mechanisms that were maybe impacting upon treatment outcomes wasn't really kind of happening yet within young people. And when we were establishing our research and thinking about what we wanted to look at and what we wanted to think about was thinking about those mechanisms that might be kind of underpinning the maintenance of symptoms during treatment. And this is because, as people have said today, CBT and SSRI medication are very effective in reducing BDD symptoms for people, but there is still that variability in treatment response. So this is quite kind of an old review now, but in 2016, kind of 40 to 60% of patients didn't achieve responder status. And in a review that we conducted this year, there was 11 papers included that were exploring predictors of treatment outcomes in CBT, and they explored 56 different predictor variables. And of those, there was no variable found to consistently predict CBT response. So it feels really unclear there what kind of factors are impacting upon treatment outcomes. I've just put some examples here of some of the variables that were looked at. So things like insight, depression, BDD symptom severity, treatment credibility, and duration of BDD. So we were interested then in thinking what other potential factors might it be good to explore within BDD, and we landed on family accommodation, and this is because of the kind of similarities that exist between BDD and OCD. And with regards to family accommodation in OCD, there's kind of lots of literature and research on it, and it is found to be very common. So up to 99% of parents accommodate their child's OCD symptoms. And whilst that's so understandable because they're trying to reduce the distress and it is a way of providing that short-term relief, it has been associated in the longer term, and I guess these associations have been found between high levels of family accommodation and greater OCD symptom severity, worse global functioning, greater internalising and externalising difficulties, high parental psychopathology, and also very importantly, family accommodation that's higher in OCD has been associated with poorer treatment outcomes, so it's a really important thing to target within the existing treatments. In BDD, Jassy et al. Qualitatively explored family accommodation in BDD in interviews with young people, with parents and carers, and with clinicians. And those kind of the accommodation behaviours that were reported were very similar to those found in OCD, so things like supporting avoidance, providing reassurance, and also parents reported that they kind of engaging in family accommodation impacted upon their own mental well-being, their finances, their social functioning and family functioning as well. So we decided that it was important to quantitatively explore family accommodation in young people, and we focused on maternal accommodation only, so mother-reported accommodation. This was because the clinical data that we used that was existing, mothers were the primary caregiver for the majority, so we really just focused on mums in this sample. And we had 3 aims: exploring the patterns of maternal accommodation assessment, looking at demographic and clinical correlates, and investigating associations between maternal accommodation assessment and treatment outcomes. So to do this, we had a clinical cohort of 131 young people with BDD and their mothers. So the young people were seen by the Maudsley Hospital, the National Specialist OCD, BDD and related disorders team, and their mothers had completed a measure of family accommodation at assessment. And just some kind of characteristics of the sample. So 82% of the young people were female, 74% white British. The mean age was 15.7 years. And of those where we had data available about comorbidities, it was about 90 of these young people. 22% had co-occurring OCD and 23% had co-occurring ASD. And just to give you a sense of the severity of the BDD within the sample, the mean score on the BDD Y box was 34.9, so these were young people who were particularly unwell. And we kind of followed this cohort through treatment, so there was 70 young people of those who received treatment, so this was CBT for BDD, and they had post-treatment measures completed as well. The CBT was protocolized and delivered by clinical psychologists, trainee clinical psychologists, and it was the weekly sessions incorporating all the CBT components that you're all familiar with. And importantly, I guess, for this research, the extent to which maternal accommodation was explicitly addressed in treatment varied for each young person, depending on where that came up on their hierarchy of compulsions. The measures we used, so we used the BDD-Y box, the gold standard measure of symptom severity. Clinicians also reported a measure of the child's global functioning as well. The young people completed the self-report measure of appearance anxiety, and mothers completed the family accommodation scale parent reports, which is the self-reported adapted measure of the semi-structured clinician-administered interview, and they also completed the depression, anxiety and stress scale as a measure of the maternal psychopathology. So I'm just going to very briefly, before I go on to the results, just discuss the psychometric properties of the FAST parent report version, because it's been widely used in OCD, but in BDD it hadn't been used yet. So we undertook an exploratory factor analysis, and we found a very similar two-factor solution to that found in OCD samples. So we named those two subscales modified routines and involvement in rituals. And the internal consistency as well, we explored that, and that was excellent within the sample for the total score. So that suggested the reliability and validity of the measure before we move forward with the analyses. So with regards to the first aim, the frequency and patterns of maternal accommodation, we found that all mothers in the sample endorsed engaging in at least one form of accommodation on the family accommodation scale, and actually 76% reported daily accommodation on at least one of the items on the FAS. And in the figure here, this summarises the percentage of mothers who reported that they engaged in the accommodation to a severe or extreme extent. So this is happening at least 3 times a week in each of the items there about those particular behaviours. So you can see that providing reassurance was the most common, and that was facilitated by assisting in avoidance. And overall, we found that 99% of mothers reported providing reassurance. That was particularly high. In terms of clinical correlates, actually, I should go back. Demographic correlates, age and sex weren't associated with family accommodation. That was the first thing. And then with regards to the clinical correlates here, so higher levels of maternal accommodation were associated with worse child global functioning and greater maternal psychopathology. And interestingly, I think this kind of was different to maybe what we expected based on the OCD literature, that maternal accommodation was not significantly associated with BDD symptom severity at assessment. And lastly, thinking about treatment outcomes, so we were interested, did maternal accommodation assessment predict post-treatment BDD symptom severity? We used a regression model here that controlled for those variables that were significantly associated at baseline, so the CGAS and the DAS, and the BDD Y box as well, just to control for that severity at baseline. And we found that there was no association there between maternal accommodation assessment and treatment outcomes. So taking this together, I guess our first conclusion is that maternal accommodation is common in BDD, particularly the provision of reassurance. However, there seems to be a different relationship going on to what we find in OCD, so it doesn't appear to have that same relationship with symptom severity that we see in OCD, particularly in young people. And we wonder here if there's something about the ritualistic behaviours in BDD that feels different to OCD, that lots of these maybe being private, so young people can covertly engage in behaviours kind of mentally, or they can check in a mirror on their own without needing any involvement from others, and maybe that reduces the impact that maternal accommodation has on symptom severity. And we also wonder if maternal accommodation was associated with comorbidity within the sample, so whether accommodating behaviours were occurring in the context of BDD existing and sitting alongside OCD or ASD, or it might be depression, just different difficulties that might have been present for these young people. And this is something that we are in the process of looking into. And clinically, it does suggest that targeting accommodation by working directly with parents is maybe not as important as it is in OCD treatment. However, there were still associations there with some of the variables, so it does feel like an important factor to consider during CBT for BDD with young people, particularly around providing reassurance, which is extremely common, and also as well flagging up providing items, because that's something that can be associated with huge financial burden for families, providing those items for their different rituals and behaviours. It's important to consider in terms of wider functioning, and also remaining really sensitive to the needs of, within this sample, it was mothers, but parents more broadly, and thinking about if they're presenting with their own psychological distress, how do you signpost them to appropriate support? There are various limitations to consider of the study. Whilst it was a large sample, there is issues around generalisability. So the sample was majority white, majority female from a specialist clinical context. So we don't know how this applies beyond this. As I mentioned earlier, comorbid diagnoses, there might be things at play there in terms of accommodating behaviours. It was a cross-sectional design, so it's difficult then to establish kind of direction of relationships. It was only at one point in time. And also the self-report measure of family accommodation. There might be limitations to this. Some mothers might have differed in the extent to which they understood BDD, the extent to which they understood the construct of family accommodation, and they also might have been reporting on behaviours that were accommodating other things than the BDD itself. And then thinking forward to kind of where future research should go with this. So I think paternal accommodation is important to look at. Obviously, this just focused on maternal accommodation, and in OCD, whilst it's been found that there is similarities in that both parents accommodate, and we're thinking very heteronormatively here about mother and father, but when both mum and dad accommodate, it might be that mums accommodate more, so it'd be interesting to see what patterns exist there with BDD, with young people with BDD. It's important to explore a bit further the comorbidities that might be at play and influencing these relationships that have been found. And also, I guess, developing different ways of measuring family accommodation. So given those potential limitations with relying on a self-report, actually, can we use clinician-reported measures, observations? Can young people report on family accommodation? That might be interesting to see what similarities exist between the different perspectives and what relationships exist there. And I think as well, beyond I've kind of zoned in here on family accommodation, but beyond that, there is those inconsistencies that exist in treatment outcomes, and I think doing more research to look at those mechanisms that are underpinning treatment, what kind of characteristics, which other people have talked about today, think about predictors and things, what other mechanisms are at play that are keeping symptoms going, I guess, so that we can create treatments that do result in more consistent outcomes for people accessing them. So thank you very much, and if anyone has any questions, I'm more than happy to answer.